Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Ayman Abdelhadi. I am an associate professor of cardiology at Ain Shams University, Cairo, Egypt. And I am a consultant adult cardiologist at Riyadh Care Hospital. Our subject today is going to be about resistant hypertension. And to start with, the best thing is to define what do we mean by resistant hypertension. Resistant hypertension means blood pressure that stays beyond the recommended guideline levels after treatment with 3 or more antihypertensive medications. Now, preferably, one of those agents should be a diuretic. The second thing to remember is that while treating the patients, they have to be at the optimal, if not the maximum tolerated doses. Now, despite the many therapeutic options available today for treatment, a good deal or a good number of patients remain uncontrolled. Now, unfortunately, the control rates does not exceed 50% in the best communities, and it goes down to 15% in some countries. Meaning that patients with resistant hypertension constitute about 10% of this population. But if you take into consideration the number of patients who remain uncontrolled, if we suppose those are 60%, then 10% out of that is actually a large population. So, what is the objective of our presentation today? Objective is number 1, to identify those at high risk, and number 2, to try to find the reversible causes for resistant hypertension and try to modify the therapeutic options in order to improve blood pressure control. Now, in order to go into more details, let's say that the use of diuretic is recommended, as mentioned earlier, but it is not mandatory. Those should be optimal. It doesn't have to be the maximal, but at least it should be optimal. And those who are receiving more than 4 medications should be considered having what is known as controlled resistant hypertension. And those patients should be looked at as a separate entity. Now, one of the most important reasons for what is known as pseudo-resistant hypertension is advanced atherosclerosis, especially in the elderly. We are going to see the criteria of those patients later on. But most importantly is using a wrong cuff size or having excessive atherosclerosis sometimes gives you high systolic blood pressure, very low diastolic blood pressure, and can falsely diagnose resistant hypertension. Now, what are the criteria for those patients? Usually, they have a higher baseline blood pressure. They are older in age, obese. They are eating excessive salt in their food. They might have chronic kidney disease, which is not over yet, and most of them are diabetics. What about the associated criteria? Well, female gender remains an important criteria. African American race, and the presence of left ventricular hypertrophy either in the ECG or the echocardiography. What about the lifestyle factors contributing to resistant hypertension? These include obesity or overweight, high salt diet, physical inactivity, ingestion of high fat, low fiber diet, and heavy alcohol ingestion. Now, what about the causes of resistant hypertension treatment? Poor adherence with the prescribed medications. This is a very important factor. Patients come to the clinic, but they do not admit that they are not taking their medications regularly or as prescribed. Inaccurate blood pressure measurements, and this is very frequent, especially in the primary care units, and if the blood pressure is measured by an untrained personnel. And the last and the most important is white coat hypertension. Now, how do we evaluate a patient with resistant hypertension? First of all, you have to confirm the diagnosis. How to confirm the diagnosis is to make sure that the patient is taking their prescribed medications on time and with the accurate doses. And second, you have to identify other causes, especially secondary causes, and we are going to talk about those in a minute, and to document whether you have any target organ damage or not. Now, substances that can interfere with blood pressure control. We call this sometimes polypharmacy. Most of our patients are elderly. they are receiving non-steroidal anti-inflammatories, and some of them are, or most of them are receiving aspirin. Now, those medications cause salt and water retention and can add to the problem of resistant hypertension. Some sympathomimetic agents like decongestants, those medications used to treat blocked noses during cold, and diet pills as well as cocaine. And some stimulants like methylphenidate and the amphetamine with all its derivatives. All those medications, most of these are used especially by students during examination times, and those medications can result in severe hypertension. Other substances that can interfere include alcohol, oral contraceptive pills, especially for females, cyclosporine as an immunosuppressive agent, erythropoietin in chronic kidney disease patients, natural licorice, and some herbal compounds, including ephedra, which has ephedrine and pseudoephedrine in it. What about the secondary causes? This comes as a very important, there are some common diseases that causes resistant hypertension, including obstructive sleep apnea, renal parenchymal diseases, which passes undiagnosed due to normal creatinine, especially in the elderly, primary hyperaldosteronism, and renal artery stenosis. Now let's talk about primary aldosteronism, and the reason why I concentrated on this, because this problem is not uncommon. The prevalence, as you can see, is rather high. It's about 6.1 and goes up to 13% in patients with uncontrolled hypertension, that is blood pressure more than 180/110. You don't have necessarily to have low potassium to diagnose hyperaldosteronism. Potassium can sometimes be normal with a patient having resistant hypertension. So how do you make the diagnosis? You have to do a renin stress test. Primary hyperaldosteronism is very common and usually contributes to 20 to 30% of the cases of resistant hypertension. Other secondary causes include pheochromocytoma, Cushing's disease, hyperparathyroidism, aortic-arcutation, and intracranial tumor. What about the treatment? First of all, you have to confirm that you have resistant hypertension. You have to exclude pseudo-resistant if possible. You have to exclude white coat hypertension, and you have to make sure that you don't have any of the secondary conditions. So, office blood pressure should be less than 140/90. If it is more than that, or more than 130/80 in a diabetic patient or a patient with chronic kidney disease receiving 3 medications at optimal dose, this diagnoses resistant hypertension. More than that, if the office blood pressure remains or requires more than 3 medications, then this definitely diagnoses resistant hypertension. Now, the first thing is to exclude pseudo-resistant, as we mentioned earlier. Is the patient taking his prescribed medication? Is the patient taking the medications at time? Is he taking the correct dose? Is he tolerating the optimal and maximal dose or not? So you have to obtain home, work blood pressure. And ambulatory blood pressure sometimes can also be helpful, especially to rule out white coat hypertension. What about the other reversible contributing lifestyle factors? These include obesity, physical inactivity, high salt, low fiber diet, and excessive alcohol. Now this diagram shows you clearly the effect of lowering salt ingestion on blood pressure. You can see in the red graph that those patients who were receiving high salt diet, they had a blood pressure, average systolic blood pressure of 150 and a diastolic of about 120. Now, when those patients were advised to reduce their salt intake, although they were receiving 3 medications, what happened is that their blood pressure dropped dramatically. As you can see in the orange graphs, their systolic became 130 and their diastolic became an average of 70. So the average decrease was about 20 millimeters of mercury in systolic blood pressure and about 8 millimeters in the diastolic blood pressure. You have to screen for secondary causes of hypertension. Those include obstructive sleep apnea. You have to ask about snoring or especially, you know, in these conditions, we ask the wife, do you feel that your husband stops breathing at night when he's sleeping and then suddenly resumes sleeping again? This usually confirms the presence of obstructive sleep apnea. Primary hyperaldosteronism, elevated aldosterone-renin ratio. Chronic kidney disease, creatinine clearance. Don't rely on creatinine level alone. Sometimes the creatinine clearance is low and you have normal creatinine, especially in the elderly, frail, and underweight. Renal artery stenosis, especially in the young females, or if you have atherosclerotic disease, or fibrodysplasia, or worsening of the renal function in a patient with hypertension, especially after the addition of an ACE inhibitor or an ARB. Pheochromocytoma. We all know the episodic hypertension with palpitation, diaphoresis, and headache. Cushing's disease, they have characteristic features like moon faces, central obesity, and abdominal stria. And finally, aortic coarctation, which usually presents in the form of hypertension in the upper half of the body and normal blood pressure or even hypotension in the lower half of the body. What about treatment? Again, pharmacological recommendations. Number one, you have to stop medications or substances that interfere in blood pressure control, like non-steroidal anti-inflammatory and stimulants and the decongestants if possible. You have to use the long-acting forms of thiazide diuretics, especially chlorthalidone. You have to combine agents with different mechanisms in order to be able to target the blood pressure control at different levels. And the best recommended triple regimen by the guidelines includes an ACE or an ARB with a thiazide or thiazide-like diuretic and a calcium channel blocker. So these are the combinations approved by the GNC-7. We are still awaiting the GNC-8. It includes either an ACE with a calcium channel blocker, ACE with a diuretic, ARB with a diuretic, beta blocker with a diuretic, centrally acting drugs with a diuretic, and diuretic with another diuretic, which is one is potassium saving and the other one is salt losing or sodium losing. Now you can combine all three of them either in one tablet, 2 or 3 tablets, it's up to you, and then you titrate the dose to the maximal in order to be able to control the blood pressure. If suppose the patient is not controlled and you are suspecting hyperaldosteronism, what you do is you add a mineralocorticoid receptor blocker. We usually use aldosterone. This is the only medication available in our country. Eplerenone is not available here. And usually you will find that once you add this anti-aldosterone, the blood pressure goes into control, and sometimes you even cut down on the other medications. In chronic kidney disease patients, they sometimes need a loop diuretic in order to be able to reduce the volume, because one of the main causes of resistant hypertension is volume. And of course, dosing schedule, it is always advised to put at least one of the medications or to take at least one of the medications at night. Now, if you are unable to control the blood pressure, or if the patient starts having complications like kidney disease, or he's diabetic, or he's having myocardial infarction or ischemia or any cerebral problem, you should refer him to a specialist, either to an internal medicine or hypertensive specialist, or to the appropriate specialty if he's having kidney or cerebral disease. What about controlled resistant hypertension? Those patients are at increased risk of secondary causes of hypertension, so they should be screened. Medications should be revised and should be titrated so that they are using the least number of medications or the maximum tolerated in order to avoid side effects. This is just an algorithm to show you how can we deal with resistant hypertension in 2012. First of all, you should have a suspicion. Patient, usually elderly, receiving more than 3 medications, optimal dose, one of them is a diuretic, and his blood pressure is still above the recommended targets. So this diagnoses resistant hypertension. First of all, you have to exclude pseudo-resistance. You have to make sure that he's taking his medications at time, that he is taking medications at the recommended doses, He doesn't use any other medications or any other substances that interferes in blood pressure control. And once this is achieved, especially or usually with the history and physical, you have to exclude white coat effect. 20% of the patients coming into the clinics to check their blood pressures develop hypertension because of what is known as the white coat effect. And this can be very easily ruled out by doing an ambulatory blood pressure monitoring or monitoring the blood pressure at home. Once you do that, then, and you have the diagnosis of resistant hypertension, you have to start managing those patients. Number one, you have to check if they have any target organ damage, because at this moment or at this time, you have to be very aggressive with your treatment. You have to look for any comorbidities like obesity, like anxiety, alcohol consumption, smoking, diabetes, and so on. Have to make sure that they are adherent to their medications. They have to restrict the salt intake to the minimal. And then you start screening for secondary causes if all these factors were corrected and you are still facing the problem of resistant hypertension. This is a catheter. It's a radiofrequency ablation catheter. This is now the latest trend in the treatment of resistant hypertension. They use it to do what is known as renal artery catheterization, and they do radiofrequency ablation to the sympathetic innervation at the proximal ends of both renal arteries. The results are very, very encouraging. Patients who underwent these procedures for diagnosed and confirmed resistant hypertension were able to reduce their blood pressure. Not only that, but reduce the number and the dose of medications they are receiving for hypertension. So it seems this will be the next era in the management of resistant hypertension in those patients after excluding pseudo-hypertension, pseudo-resistant hypertension, and white coat hypertension. So what is the take-home message for today? Number one, resistant hypertension, 10% of the population. Numbers are higher when the population control percentage is higher. It should be differentiated from pseudo-resistant hypertension and from white coat hypertension, very importantly. Non-compliance is one of the major reasons or causes of resistant hypertension. Primary hyperaldosteronism, don't ever miss it. Always think about it when you are unable to control the blood pressure. Low renin-resistant hypertension responds to aldosterone blockade, and normal blood levels of potassium does not exclude hyperaldosteronism, especially the primary. Ambulatory blood pressure monitoring is mandatory in order to differentiate resistant hypertension from white coat hypertension. Patients with white coat hypertension are at increased risk of target organ damage. They are usually anxious and they have tachycardia in the clinic, and that's one of the criteria in order to differentiate those patients from resistant hypertension. It remains controversial whether it is necessary to start treatment for those patients with white coat hypertension or not. But if their blood pressure remains high, especially at home, or if you start to notice that they are having target organ damage, then yes, definitely they require treatment. But unfortunately, until now, we don't have any clear guidelines for that. White coat hypertension, always remember that it might not be entirely a harmless phenomenon.